Okay, good afternoon, everyone. Good afternoon. We'll get started. I'd just like to begin by acknowledging the Ngunnawal people, who are the traditional custodians of this land on which we are meeting, and pay respect to the elders of the Ngunnawal Nation, both past and present. I extend this respect to all Aboriginal and Torres Strait Islander peoples in attendance today. So thank you very much for coming. This is a really great turnout. So my name is Nathan Dacuna, and I'm the chair of the AAG committee here in the ACT. So this is actually the first event that we have held since September 2019, which not only seems like a long time ago, it was a really long time ago. So it's fantastic to see you all here, and it's great to be back hosting this as a face-to-face meeting. We're only the second AAG division to be hosting a face-to-face event since COVID-19, or should I say since we all started using Zoom all of the time. And so welcome to those of you who are watching on YouTube as well. So we have a very interesting presentation for you today. And while I'll let Michael introduce this very important topic, I'd like to officially welcome Michael to our committee here in the ACT. And I'd also like to thank Michael for bringing this together today. So before I exit, unfortunately, we're unsuccessful in being able to organise free parking. So if anyone does need a ticket, I have a very small number of those, so please come see me afterwards. Okay, so thank you again for coming, and I'll hand it over to Michael.
Hi, everyone. My name is Michael King. I'm a consultant physician based at Calvary Hospital, Bruce. And thank you all for coming to join us in discussion regarding delirium and modern tales. So just to disclose, I've got no financial ties to disclose, but I am a fellow of the Royal Australasian College of Physicians. And I do have professional memberships with the AAG, ANZSGN, and INSANS, which are my professional bodies that I'm involved with. So before we talk about delirium, I guess I first of all wanted to start off with describing, as a geriatrician, what do I exactly do? And the big question is, if you see a cardiologist, you know that they deal with the heart. If you see a gastroenterologist, you know that they will be dealing with the gastrointestinal system. If you see a nephrologist, you know that they'll be dealing with your kidneys and the associated problems. But what does a geriatrician exactly do? Do we cure aging? Do we deal with old people? Is it are we basically what a pediatrician does, but for older adults? So first of all, I am a medical doctor, and I work across various healthcare settings, whether it be home-based, nursing home-based, rehabilitation, and also within the hospital itself. And as a geriatrician, my special expertise is in management of multiple competing medical illnesses that affect our older adults, and also deal with the assessment and management of geriatric syndromes. And you might be asking, well, what are exactly geriatric syndromes? If we were to get a definition of a syndrome, it's a group of signs and symptoms that occur together and characterizes a particular underlying problem that drives it. This is a well-known graph that I wanted to take some time explaining. In a traditional sense, when we are dealing with a syndrome, patients often present with defined set of signs. Now, and it is up to clinicians like myself to analyze those symptoms and signs and to identify the cause, the etiology, and how it leads to the set of signs, i.e. the pathogenesis. What's emerging and what's unique about geriatric syndromes is that older adults present with unified symptoms or manifestations, just like how, in a traditional sense, how a syndrome would present. But what's more interesting is that within this unified manifestations, multiple causes and multiple pathogenetic pathways interact, leading to the final outcome which we see by the bedside, how the patient presents. Due to the multifactorial nature of geriatric syndromes, it is my role to conduct what's called comprehensive geriatric assessment. And what that entails is a comprehensive assessment of 4 main domains. Traditionally, in a medical sense, we deal with the physical health. We look at the symptoms and signs and prescribe a treatment strategy. But in comprehensive geriatric assessment of an older adult, we also take into account their cognitive and emotional health, the social support surrounding the older adult, and finally, the external environment in which the older adults live in. Because all of these 3 other factors actually play an important part in how a patient presents with a geriatric syndrome. And in order to do a comprehensive geriatric assessment, we also rely heavily on our nursing colleagues as well as allied health staff, because one person cannot actually deliver the comprehensive care that the patient requires. So it is a team-based approach for what is a complex issue. So some common geriatric syndromes that we encounter in day-to-day practices could be falls, incontinence, functional decline, frailty, cognitive impairment and dementia, and finally delirium. And delirium will be what we'll be focusing on today, but I do want to again highlight the fact that when presents with falls or incontinence or functional decline, in that paradigm of geriatric syndrome, we always have to keep in mind that there are multiple pathways and causes that's contributing to the eventual presentation of geriatric syndromes. So what exactly is a delirium? And the reason that we decided to focus as Australian Association of Aging for this seminar, why we decided to focus on delirium, is that there's a great deal of confusion, no pun intended, about what exactly it is, and there's a poor recognition and poor understanding of healthcare professionals and public alike about what exactly it is. It is a specific medical condition that's characterized by a sudden change in cognition. There's also a profound inability to clearly think and pay attention. Not only that, there is a degree of fluctuation and severity throughout the day. So most often, what people describe is that when the doctors come around to see their patients in the morning, patients are fine. But as the day progresses, the nurses and the allied health staff start to notice that their cognition start to get worse. And sometimes it can be not identified due to its fluctuation in nature. And finally, delirium is caused by an underlying medical illness which drives it. And this is so important, that delirium is actually caused by something. And when delirium is identified, we actually have to do investigations to identify what's driving it. And Stella, the nurse practitioner today, will be discussing more about this. Brief history regarding delirium is that it was first described by Hippocrates in 500 BC, where he described a mental abnormalities caused by fever, poisoning, head trauma. The term itself, delirium, comes from deliro delerare, which means to go out of the furrow, where it means deviate from a straight line, to be crazy or deranged, out of one's wits. And the term was first coined by a physician by the name of Celsus in the 1st century AD. So the disease has been known for many thousands of years. And then you may ask, who can actually develop delirium? Well, the simple answer to that is anyone, if the illness is severe enough. However, we do know of certain risk factors in which causes people to have more likely to develop delirium. And the greatest at risk are our older adult population, male gender, somebody with underlying dementia. And in order to describe why that is, I often give an analogy of an object, or let's say a car that was broken once, is more likely to break down again. So somebody with vulnerable brain is more likely to undergo acute brain failure, which essentially is delirium. So somebody with underlying brain disease is more likely to develop delirium. The severity of the medical illness, hip fracture, and number of medications, especially if they act directly on the brain, and also hearing and visual impairment. Someone may ask, well, isn't it just dementia? And the reason this table is so important is that there are key features which differentiate delirium from dementia. Compared to dementia, delirium has a very sudden onset over hours to days. And as I previously mentioned, there's a fluctuating nature to it. And the duration of delirium is, again, much shorter, and often people's consciousness is impaired as well. While as dementia, usually the cognitive impairment is insidious and it develops over months to years. It's progressive and duration is months to years as well. And often dementia is irreversible. And this table is probably key because one of the most common questions that get asked by family members is somebody presents with delirium who has existing diagnosis of dementia, and they ask me, well, my grandmother or my mother or my father, I think their dementia symptom is getting worse, and I think they need to go to a nursing home. And it is somewhat very surprising that how common that question actually gets asked to me on a day-to-day clinical practice. And each and every time I actually have to let them know that what we're dealing with is actually delirium and not dementia. And once we identify the cause which drives the delirium, then often people's cognition can return closer to baseline, which means that we can avoid other life-changing decisions. Then the question is, well, what is the big deal with delirium? And what I just want to highlight to you is how common delirium actually is in hospital setting. These are some infographics based on data directly from Australia. So 10% of patients aged 70 and over in hospital actually have delirium. That's 1 in 10. Not only that, if you take patients in intensive care unit, up to 80%, that's 4 in 5 patients can have delirium. And as I previously mentioned, people with underlying brain disease, such as dementia, are 6 times more likely to develop delirium. And this is a study based in UK. And what this shows is that when we stratify the patient populations according to age, as patients get older, the prevalence of delirium increases to upwards of 35% in 80 plus years old. So it is a disease that's more common in older adults. And what I always tell my students in terms of residents is that delirium is a medical emergency. And the reason that is that it's actually easier to prevent delirium than to treat. And up to 30 to 40% of the cases are actually preventable. What's really worrying, especially within Australia, but also worldwide, is that half of the time, delirium is misdiagnosed. That's pretty scary. And I've seen that on a clinical practice where people have written in the notes, patient is pleasantly confused, pleasantly demented, walking around naked in the ward, seemingly confused. All these terminologies that describe exactly the symptoms of delirium, people just do not use the right word, delirium, which triggers the right set of actions. And often when I'm teaching students about delirium, the analogy that I give is, if you see a picture of zebra, you should call the zebra for what it is, which is zebra. But instead, in clinical practice, it seems like people are calling it as white horse with black stripes or black horse with white stripes, and just beats around the bush. And the reason is, as long as you don't call delirium for what it is, it in some ways, psychologically, does not, it stops you from taking further actions about the problem at hand, because you're not defining what it is for what it is. And not recognizing delirium is a safety and quality issue, and Australian health and quality standards are really the driving force in improving delirium recognition and management in hospital setting. And this is quite scary. Patients with delirium have more falls, pressure injuries, functional decline, and ongoing cognitive difficulties, even when delirium resolves. More likely to die. 45% of delirium patients in older adults have unresolved cognitive impairment when they leave hospital, and they are twice as more likely to go into nursing homes. And what I want to leave you with before I hand over to my next speaker is this figure. In 2015, 12.3% of total worldwide population was aged 60 plus and above. When it gets to 2050, this proportion is going to be 1 in 5. What this means is that diseases that affect older adults, such as delirium, is going to become more and more prevalent. And if we don't do something to increase public and healthcare practitioners' awareness of what delirium is and what we can do about it, the healthcare cost and impact upon patients of our older adults who are especially vulnerable is going to be significant. So I'd like to introduce my next speaker, who is Stella from Modern Medicine Clinic in Braddon, and she'll talk to you more about delirium.
Thanks, Michael. I'll just make sure I know how this works here. So the next one down. I'm not really good with tech stuff when I don't know it. Is it? Oh, no, it's yours. Beautiful. Okay, here we go. Next. All right, so I thought I'd first of all tell you a bit about nurse practitioner and what we actually do, and because I'm sure a lot of people think, gosh, where does a nurse practitioner fit into this delirium equation? So first of all, like Michael was saying, I work at Modern Medicine. I also do some private work at Calvary Private, just as a consultant. They call me in now and again to do some reviews of patients in there. So people that can refer to me as a family can directly refer to me, GPs refer to me. So sometimes when they refer, they ask me to do some cognitive testing on the patient to work out where they are within their potential cognitive decline, and then we refer on to a geriatrician. Nursing homes refer in if they've got unwell patients. They want to have reviewed. Geriatricians and neurologists also refer directly to me. Again, for usually the cognitive testing. The other things I do in addition to all the cognitive testing is I do capacity assessments, working out whether or not someone that has capacity to make decisions. And also I do things like organising ACAT referrals as well. I do a lot with NDIS. I arrange prior to seeing in our clinic prior to seeing the geriatrician. They come in to see me. I do the geri workup, organise an MRI, or the memory testing, bloods if they haven't had them done, but they usually do by the wonderful GPs. And then I report back to the geriatrician and the GP. So it's a team approach. That's how us nurse practitioners fit in. Okay, so I like to think about delirium as the 5 Ps. In a previous life, I used to work as a stromal therapist, so we used to think in 3 Ps. So that was poo, pee, and pus. So we just add one more to the delirium equation, and that's pain. So I suppose the thing is to think about with the elderly patients when they might present with a delirium is, goodness, what are their feet like? Do they have any ulcers on their feet? No one's been able to see, and that they might have a big abscess or something like that. So that could be causing a delirium. They could have, we like to review all their medications. Sometimes they're on too many medications, which can cause delirium. Of course, pain. People with dementia, it's very hard for them to explain to people that, they're actually in pain. So we look for a lot of facial expressions and body expressions. Poo, we always like to have a happy poo. We want to look like we've done a poo that looks like a bit of a sausage. Everyone knows what a sausage looks like from the butcher. We want something nice and soft, nothing too hard. So that's important to think about the poo. Now the wee, as you can see, that lovely cow there is doing a nice clear wee. And a good volume. So again, we're looking for a nice clear wee. We don't want something that looks like orange cordial or might have big blood stain. We don't want the raspberry cordial look either. So, and the other important thing, in addition to urinary tract infections with smelly, very unclear urine that you might see, or urinary retention, where especially in men, we often see they have retention, which can lead to delirium. So there, I think it's a good little thing to remember. All the P's. It's quite easy. Pus, pills, pain, poo, and pee. So it's a good thing to remember. Okay, so I thought I'd just talk to you about a lady that was referred to me from her daughter. So this was actually a self-referral from a lady from her daughter who was very concerned about her mum. She's an Italian lady. She was had been diagnosed with Alzheimer's disease. She was 78 years old. She usually speaks a little bit of English, but she reverted back to speaking mostly Italian. Normally, she's a lady that can look after herself with the help of a level 2 package. The daughter went to visit her. She couldn't get out of bed. She was really restless, and she called the GP. She couldn't get in to see the GP. The GP couldn't go and do a home visit, and she was known to us at the practice, so she rang and said, "Oh, do you mind coming out to see my mum? I think there's something really wrong with her." So off I went, home visit. So just quickly, again, so she's 78. The past 48 hours, she's been really restless, not sleeping, crying, shaking. She had loose bowels at the time as well. She was speaking much louder than she usually did. She was roaming around the house. When she was first diagnosed, she had a RUDAS of 19 out of 30. And the other medical history for her, which is important, is she had left hip pain, and she was planning to have a hip replacement. So the only medications this lady was on, which is good to see that she's only on a few, because us in the Jerry world, we like to cut and burn medications. We don't like too many medications. So she was just on some Panadol. She had a fentanyl patch, vitamin D. She hardly got outside, so her vitamin D was quite low. And she'd also had been on Aricept as well. So she tolerated 5 milligrams and had been increased to 10 milligrams with no issues at all, which was good. Okay, so just the initial findings, the daughter said the only way she could settle her mum was by pushing her around in the wheelchair in the house, so a bit of diversional therapy. So I thought we'd just maybe segue for a minute and just talk about some of the non-pharmacological approaches to delirium, because I think this is particularly important for everyone in hospital and at home to sort of think when someone is experienced delirium that we can maybe try some of these approaches, as well as some other bits and pieces I'm going to talk about in a moment. So I suppose the thing is, like us as clinicians, we need to make sure that we support families, educate around delirium. Try when someone is in delirium, try and orientate them so they feel safe, that they've got their personal objects around them. Sometimes this is not possible, but if you can try and do that, and sometimes having a clock to show them time as well, because if they roam around at night, you show them that it's 1 a.m. in the morning, that perhaps they should be sleeping, would be a good idea, rather than trying to make themselves breakfast. Just make sure you're not using, make sure they've got their glasses on, use a translator in hospital if it's necessary, if you're trying to have a conversation. Don't use too much medical jargon, because they're not going to understand it. As we know, people who have dementia and develop delirium, if you say 5 words, they only basically hear 2, so it's very confusing for them. Make contact with them. Don't be looking over here, sort of look at them, maybe touch them if it's appropriate on their knee or arm. You probably know the patient quite well, so if it's appropriate to actually touch their arm. Some people it's not appropriate, but some people don't mind. Make sure that the radio's been turned down. It's a quiet environment. Often you walk in and the TV's really loud. Turn that down. Make sure if it's not perhaps too dark, the lights are appropriate. And also, don't restrain them. Don't tie them up if you're trying to keep them in one place. It's really, obviously not appropriate. And things like, try and make sure that you can get some hydration into some fluid, really encourage them, to maintain some self-care as well. So now let's go back to our lady. So Mrs. B, so I'm at the house, I'm doing an assessment. So first of all, I get a urine sample. I have a little kit, a doctor's kit, I suppose, or I should call it a nurse practitioner kit. So I take her temperature. Her temperature was okay. Her pulse was within her normal range. There was no postural drop with her blood pressure. I listened to her lungs. They're okay. I have an oxygen saturation machine. We checked that. It was 96 on air. That's okay. Her skin wasn't the best, but that's probably due to dehydration, not drinking enough. Her abdomen was nice and soft, so there was no constipation. Bowel sounds were very hyperactive. She had that little bit of loose bowels, remember. I did a full delirium screen of blood, so hemoglobin, white cells, neutrophils. They're looking for whether or not the CRP was actually elevated. So I didn't know at the time when I was there whether or not they're okay. Of course, we sent all those bloods off, and they all came back and they were normal, which was good. So just this lady, so she was continued to speak really loud. She was restless. She was agitated, crying. She was rocking back and forward in her chair. I was unable to do a RUDAS to see how it compared to her initial one. So that just wasn't possible. She was way too restless and agitated to do something like that. So now, any thoughts what might have caused her delirium? Now, Michael, you're not allowed to answer this because you've read my slides. So any idea why she might have developed a delirium? Yes. Pain. She has got pain. Why has she got pain? What may have happened, do you think? What was that?
A fall.
A fall, maybe. Yeah, that's... Beg your pardon? Her bloods were okay and there was no infection, but that's... you never know, could have been. Okay, so just recapping really quickly. So this was definitely a delirium because it was abrupt. There was fluctuation in how she was throughout the day. There was no attention because I couldn't get the RUDAS. She had disrupted sleep. She wasn't orientated to time or place. Her behaviour had changed. Her speech was incoherent. Thoughts were not organised, but she wasn't delusional, and she didn't have any hallucinations or anything like that. So it was definitely a delirium. Okay, so now what actually happened with this lady? Just to recap, so she was crying out, confused, and so when I examined her, because I sort of, had a really good look at her physically, I actually found that her fentanyl patch hadn't been replaced. So someone had come in, they did a wonderful job of caring for her, took off her fentanyl patch, gave her a shower, and then got her lovely and dressed. And then so after a period of time, about a day or so, this behaviour started to increase, like her restlessness, agitation, the pain from the crying. So she actually was having a withdrawal from the fentanyl patch. So I talked to my fabulous team, the geriatrician and the GP, and we decided that we would admit her to hospital and give her some analgesia in the hospital, try and stabilise her because she was really quite out of control, and then could recommence, obviously, her fentanyl patch once we had given her some IV analgesia or IM. So I suppose it's just, a real reminder. It's really hard to sometimes to recognise pain in the elderly, and it's really important to remember to make sure that their pain medication is actually kept up to them, because delirium can be caused by pain. So then, as a nurse practitioner, what do we do once this lady's discharged from hospital? So I then, once she was discharged, her pain was under control. I then popped home to see her. We did a RUDAS. It was 17 this time. It was 19 initially. So there was a slight decline, but, everyone has fluctuating days on, whether they remember different things. Even I do. So then we gave some education to her carers about the importance of replacing their fentanyl patch. We set up a chart that they had to sign off anyway, but another chart just to decrease the chance of happening again. We actually increased services in the home because we did find that she was struggling a little bit more when she did go home. So thank goodness she ended up happy again, and hopefully she'll get her hip replacement soon. Just other causes of delirium, as Michael did talk about a little bit, but just to remind everyone, is just, obviously you can have, due to too many medication, you can become quite toxic. Alcohol and drug intoxication could cause, and withdrawal can actually cause delirium, injury, infection, metabolic imbalances, which can be caused by different comorbidities and cause low potassium and calcium, and terminal disease as well, and severe and chronic illnesses. Okay, so I think it's really, really important as caregivers, and we really, and also medical people, we really must make sure that we educate the family and, say that this delirium is temporary. Suppose delirium and dementia are not sexy things to talk about because people get quite scared by it. They're afraid that, gosh, this delirium's occurred. It's this, manic person that's gone crazy and then they're not going to revert back to normal. I've heard that so many times. Even this week in the clinic where I had this lady come in, she goes, I just couldn't believe, my husband was in hospital, he was pulling all these tubes out, and and she thought, what is going on here? Didn't quite understand what was going on. And it's really important then, the patients often remember as well part of their delirium, and, it's okay for them to talk about their fears. They've often remembered different visual things that they may have seen during their delirium. It's good to sort of, talk them through that as well. And it's important us as well to make sure that we give all carers and families lots of support and information around delirium. So I suppose, it's delirium screening, basically should be routine. We should be doing it all the time, and we should always be handing out information to carers and families. So there we are. Okay, so our next person is Jane, and Jane's going to talk about some of her personal experiences with someone who had Parkinson's and then developed dementia and also had experienced delirium. So a personal touch on delirium. Okay, Jane.
Hello, everybody. My husband, Dr. Wright, recently did pass away in February. But before that, I only got here, you can tell by the accent, I haven't been here too long. And it's been 8 years ago that I came, and we had 8 of the sweetest years in either of our lives. So I'm really glad for that. However, when I arrived, I did know he had Parkinson's. And less than a year after we were married, he developed lung cancer. Luckily, it was caught early. Actually, it was caught accidentally. They were really looking for something else and saw this lesion and said, "What's this?" And so it was able to be addressed soon. And they got it all with surgery, and there was no chemo or radiation necessary. So that was great. However, the first exposure I had to his hospital delirium was after the surgery, the cancer surgery. And I did know that he had post-traumatic stress disorder also. He had a lot of complex conditions. So I wasn't entirely surprised when they called me the morning after his surgery, first night he'd been there, and said, "There's been an incident. We want you to know about it before you get here because he's really quite agitated and we didn't want you to walk in on it cold." And so when I got there, first of all, his Parkinson's was completely out of control. He had such violent dyskinesia that I didn't see how he was going to have any energy left to heal. He had a huge gash in his back where they had to cut him open and take out half a lung. He had been convinced overnight that the nurses were going to pour gasoline on the bed and light him on fire. And he was completely convinced of that. And this is the kind of thing that post-traumatic stress disorder sets you up for, because with post-traumatic stress, it means that you've had your ability to protect yourself violated at some point. And you've had your autonomy taken away. And when you wake up in the hospital and you're pretty much confined to the bed with all these tubes and machines and stuff, you're going to feel like your autonomy has taken away, because it has. So if you've experienced trauma, you're going to try to reassert your autonomy and take your own life back. And that's what he was trying to do. He was trying to get out of the bed, especially when he was convinced that these people that had taken his autonomy away had bad intent, as someone had in the past. One of the things that I've had a lot of opportunity to observe post-traumatic stress disorder, and one of the things that makes it really hard to deal with is that it's real. Life has taught you with real experience that you can lose your autonomy and terrible things can happen to you. So you're going to have a big reaction if you feel like it's happening again. and he did. Where the stuff about the nurses setting him on fire came from, I'm not sure. But that was his delusion. And he was trying to get out of the bed, as anyone would if they felt like they were going to be set on fire. And of course, he had a drain out of his chest, and he had all these tubes and stuff, and they couldn't keep him in bed, so they had to restrain him with straps. And he fought the straps. So when I got there in the morning, there was these big red welts on his wrists. And if they hadn't prepared me, I probably would have been 10 times as horrified as I was to see those welts. Also, I worked for a couple of years for a psychiatrist when I was working my way through uni. and I had seen some pretty bizarre behavior. So I knew that things like that might be called for. But if I hadn't had that background, I was just somebody from some small town somewhere coming in and seeing my husband that upset with big red welts on him, I probably would have assumed the worst about the hospital and the staff. So, as a matter of fact, his dyskinesia was so violent and went on so long that he did almost die that time, because he really didn't have any much energy left to heal with. But over time, things did get better, and he got out of the hospital. And afterwards, for years, we had talked extensively about what he had felt and seen when he was in the hospital that time. And I thought it had all been processed, and he was well aware that, it wasn't real. But the second time he went in the hospital, last August, when I left him, he was admitted with aspirational pneumonia. And when I left him, he seemed perfectly oriented where he was and why he was there and so forth. So I said, see you in the morning. And when I got there, I could hear him from way away screaming for help. Help, help, help. And when I walked in, there was a large nurse pinning him to the bed. And he felt he was being assaulted because he was. They couldn't keep him in the bed. They had to do it. But again, if I had just walked in on that, not knowing that this was possible, I would have been horrified. And I would have taken, and I might have taken his word for it, that they had been mistreating him, when I knew that if they had to restrain him, and it was that or straps or sedation, which with all the other things that was going on with him, that would have been a dicey proposition. So even though he'd had this experience before, we talked about it, he had processed it, he knew that people in the hospital aren't going to set you on fire and assault you and so forth. At that particular moment, he was completely convinced again that that's what was happening. And how can you say it wasn't? He felt he was being assaulted. He was being held down by a large person. So of course he felt assaulted. The thing that I found helped was to make things as normal as possible, as quickly as possible. First of all, I was somebody that he knew, and I asked the nurse to please, leave. So, because as long as she was in sight, he was afraid that she was going to attack him again. So eventually got him settled down. That was the first time that anybody mentioned the words hospital delirium to me. And it was a big relief, because up until that moment, I couldn't understand why, after the experience we'd had before, all the talking we'd done about it, all the processing that I thought had taken place, it was happening again. And I didn't understand that until somebody said, hospital delirium, it's a thing that happens. And I was so relieved. When I worked for the psychiatrist, I found that the first thing that happens on your first visit to a psychiatrist is that whatever's wrong with you, you're afraid that you're the only person in the world like that. And so the first thing they tell you is, no, you're not alone. It has a name, and this is what it's called. And the minute it has a name, it goes from being this big to this big. It has a boundary. And so there's a possibility that you can manage it. So as somebody, as the carer, as the family member, it was a huge relief to me to find that this thing had a name. So that's one thing that I would like to see people do in the hospitals, is when the family is upset and doesn't know what's going on, if you can give it a name, everybody's going to feel better immediately. So the third time he went in the hospital, I at least had a name for what was going to happen, and I was pretty much expecting it. And sure enough, the second time he went in was aspirational pneumonia again, because with Parkinson's, it's going to be either falls or pneumonia, most likely. And it was going to be pneumonia in his case. And that time he asked to go to the hospital, which was after all the horrible experiences that he had had. I knew something was different this time, because he would have never asked to go to the hospital. That's the last place he wanted to go. This time he said, I feel terrible. I think I'm dying. I want to go to the hospital. So he was there by his choice. So he had done it. This time his PTSD didn't kick in at first, because he wanted to be there. He asked to be there, and he was exercising his autonomy. And everything went great for about 4 days. But then the dementia took over and paranoia started. And so once again, he was trying to make a break for the door and telling everybody that he forgot where he was. He no longer realized that he was in the hospital where he had asked to be. Instead, what was going on in his head was that he had been involuntarily committed to some institution, and I had taken all of his money and run off with some man. And he was telling everybody who would listen that story. And the doctors, not knowing me, they didn't know what to think at first. They thought it could be true. They knew he wasn't involuntarily committed, but the part about running off with somebody and taking all his money, who knows? So just because it's happened before doesn't mean it isn't going to happen again. But it helps a great deal to know what to call it. And the only thing that the thing that I found that worked best was to try to quiet everything down and make things as normal as possible. I would show up at a regular time. We would do regular things. It was regular, just like home almost, except that it wasn't home. And that's what calmed him down. And he was responding to the antibiotics, and it looked like we might get him past the pneumonia again. But about a week into it, they found out that he was having an autoimmune reaction against his own kidneys. His body was turning on his own kidneys. And he was so frail, they couldn't even do a biopsy to figure out what was wrong. So the only choice was to let it run. So he was put on palliative care. And when they started the morphine pump, they only expected him to last for a couple of days, and he lasted 6. And but I'm glad for him now that he's free of all of that. He doesn't have to worry about people setting him on fire in a hospital bed anymore, and going back over and over and having to relive it over and over again. And so it's sad for me, but I'm glad for him. And if I've said anything that is useful to you, then I'm happy to have done it. So thank you.
Thank you, Jane, for that powerful personal testimony about encountering delirium. And I just want to thank Jane also because talking about personal experience encountering delirium, especially when it's somebody so close to you, it's very difficult and very personal. And often as healthcare providers, like myself, we do not hear the other side of the story, which is how a disease or condition that we treat day in and day out actually affect patients and caregivers. And this is one of the really rare opportunity to be able to see that and to really appreciate it from firsthand, that some things that we might take for granted or understanding and in some ways gets desensitized to. In fact, is a condition that really is life-changing and has a significant impact upon someone's life. So I just wanted to thank Jane and also Stella for coming in and presenting on delirium. We have 5 to 10 minutes of a bit of a Q&A time. I just wanted to open the forum to everybody here. I don't think people participating through YouTube probably is not able to ask any questions. Is that right? Yeah, but if anybody has any burning questions that they would like to ask, otherwise we're going to have a bit of a mix and mingle afterwards and to answer any questions or queries. So please feel free to put your hand up and ask any questions. Diane?
No one else has one, I can't see behind them. So my question relates to general anesthesia and the likelihood that people will experience cognitive problems, temporary ones, after general anesthesia, particularly as they get older. And what's that all about? Is that delirium? Is that something else?
So that's a really good question, because degree of cognitive impairment following general anesthesia, regardless of your age, is very common. And that's a personal experience for me as well, having undergone anesthesia myself. There certainly has been emerging evidences that general anesthesia can contribute to delirium, especially in older adults, and certain anesthetic agents has been implicated. And there's emerging evidences that certain agents are preferred over others when it comes to anesthesia to prevent this post-operative delirium. Unfortunately, with anything, there are multiple components at play that sometimes makes it very difficult to pinpoint anesthesia as the cause. So for example, usually people undergo general anesthesia because it's going to be a major operation that cannot be done on the local. So the very impact of having a surgical trauma and the risk of post-operative complications such as hospital-acquired pneumonia, period of prolonged bed stay, which leads to further complications, really complicate the picture and becomes a very real confounder in trying to specifically identify anesthesia as a cause. But given its associated cognitive effects, there's no doubt that it does contribute. So our anesthetic colleagues are moving towards using different agents depending on their risk profile, and doing more studies to see whether we can reduce post-operative delirium. And this is a nice segue to basically highlight the fact that this new and emerging specialty called perioperative medicine is at play, which both anesthetic colleagues and geriatricians are interested in. And basically the specialty is designed to optimize operative outcomes for our patients who undergo major operations. And what's actually emerging is that in this day and age where the surgical techniques are improving, and the patient outcomes actually now mainly driven by the non-surgery related things, so delirium, hospital-acquired infections, frailty, decreased mobility. So the role of a physician in a surgical setting has become more and more important, and this is something that is watch this space.
So we do have a question from YouTube.
There is a question from YouTube.
Yes. So what training, education, easily accessible information available do you recommend for clinical and care staff about cognitive impairments, and what is your preferred screening tool?
Well, in terms of resources, as I previously mentioned, there is the Australian Health and Quality Standards, which think I had the website put in for one of the resources where all the infographics were obtained from. So the Australian government has made patient information sheet. It was very comprehensive, and paper copies of that is actually outside if anybody wants to obtain that. But the PDF copies of that can be obtained from websites. So if that person can provide the email address somehow, I'm happy to send a PDF copy to them.
That's Kasha.
Oh, it's Kasia, sure. So I can send it to Kasia later. I think there are different screening tools for delirium. Of course, if we were to talk in depth about delirium, we could be here for a few hours. But there are some definitive tools that are available for healthcare providers. So some of it is called confusion assessment method. The other one is called 4AT. And the reason that we didn't go into that in detail today is because the scope of it and what's the best tool to use is fairly extensive. But within Calvary Hospital, we use a tool called 4AT, which is a simple and objective tool that we can use from bedside. And it can be utilized by really anyone with minimal training, and it's got good diagnostic sensitivity and specificity to diagnose delirium from bedside. And it really helps and empowers people who are using the tool to diagnose delirium. And that's really the thing that we want to achieve, is to empower people to be able to diagnose delirium, because that then spurs on action. So 4AT is the tool that I often use, and that is actually available online. And also, we all have our smartphones now. It's it can be available in a app as well. So hopefully that answers the question to Kasia. Yes.
Right. There are instances where people are genuinely mistreated in aged residential care, for example, or have bad experiences with other inmates. How do you differentiate then between whether it's a delusion and a made-up episode versus a real episode?
Very difficult. I think sometimes some of the things that patients describe when they're in delirium, it's so real to them and the description is so vivid that it's sometimes really hard to know whether it has actually happened or not. And it's really only through very careful questioning and corroboration of history between different parties involved. It's really a detective work. And sometimes I would not say that we can identify what's real and what's not in 100% of the cases. But, given that we're in a role of advocating for our patients, I think we need to give our patients the benefit of the doubt and take such claims as serious and focus all of our attempts to verify what's real and what's not. Really, as my practice is that as long as we focus our attention on the patients and really focus on improving outcome for our patients, that there's really not much room to go wrong. And it's also about listening to the patients and family members about their concerns. And I guess in terms of how to delineate what's real and what's not, as in what's really real and what's a delusional thought based on delirium, I would say I don't have a foolproof way of these are the steps that I would take to ensure that. But I would say careful questioning of everybody involved would be the way to go, and always keeping the patient at the center of our mindset. Yes.
I'm just wondering, what is the best way to calm down a patient with delirium whilst the cause is being treated?
Well, I think our mannerism is really important. Stella, do you want to comment?
Yeah, I suppose everyone is different. I can find a couple of patients I've dealt with is if you've got particular interest in something, like say if they really like art, you've got an art book, and you sort of somehow try and direct them to look at the art, look at the pictures, that can sort of help. Touch is really important as well, and just calming voice, and even going for a walk with them as as well, because you often, they are, if they can walk, they if they're not, if they don't have to be bed back, if they can walk, sometimes walking can really help as well. Just often you find they can sort of keep going and touch things and pull things, and so sometimes that can help as well. And I think it's individual, and that's why it's so difficult.
I do think communication is a learned skill, don't you think, Stella?
Yeah.
And often we get taught so much on physiology, how to diagnose, but really the very simple tool of learning to communicate gently and, with compassion and, empathizing with the patients, those are a learned skill that's done through observation of good examples, but also with practice. And, having been myself an intern, resident, then training registrar and now a consultant in a specialty, I really cannot overemphasize to our junior colleagues that you can know a textbook inside out, but if you don't know how to communicate well, really all of that is for naught, because you will not be able to establish good rapport and actually treat them effectively as one should be able to.
I really feel that they're being listened to. If someone's in your consulting room and looking around, you're touching your mobile phone, maybe even be typing notes or something like that, or writing down too much in front of them, they feel sometimes they're not being listened to. And I think, the art of listening and having good memory yourself, remembering everything they're telling you. And sometimes I just say, look, I'm just going to write something down now, and rather than just be writing all the time, so I think they're a little bit paranoid that you're writing something bad about them, or you're not actually really listening to what they're saying and doing something else. So you really need to be careful.
Yeah, I think Stella has mentioned the importance of actually making sure that the patient has glasses and hearing aids if they're required, because you can say so many things, but if they can't hear you, what do you expect them to understand? And, we have to be very sensitive to that. Often we do not actually understand, nor do we appreciate the fact that hospital is a very scary place for them, and we should really do everything possible to optimize our communication. Yes?
I was just going to ask, at Calvary Hospital, when a patient presents to A&E, do you have a tool that during their initial assessment and triage, you have a tool?
Well, that's a very timely question. The reason that I say that it's a timely question is we are actually in the process of increasing the usage of delirium screening tool, the 4AT, as I mentioned, when they first come into emergency department for all patients aged 65 and above. And you might ask, why are we using 65 as a cutoff? Why not just do everybody who comes into hospital? But as per my previous presentation, certainly there is an increasing prevalence of delirium as people get older due to it being an indirect marker of cognitive impairment and frailty. So screening tool is often the most effective when it's used in the appropriate population, and we feel that 65 and above is probably the right population to start off with. Basically the bang for your buck, basically. So we are in the process of really promoting that. And, watch the space. I think given it's so common, I think emergency department, as you say, is probably one of the most important places to start the screening process, because that's the entry, the gateway to the hospital admission. And if the delirium is diagnosed on the get-go, then actions can be taken. And that's really the area in which a lot of work needs to be done.
Let's make one comment about communication. The old-fashioned sort of way of consulting is have, like, you're on one side, then you have your desk, and then you have the patient. Well, in our practice, we try and make sure we've got the desk here, we're here, and the patient's there. So there's no barrier between you and the patient. There's no sort of desk, because I think it's a much better way to communicate too. Because sometimes you might need to lean forward, or hold their hand or something like that when you're communicating. So I think, if you're with a delirium patient, I think that's important to handle a dementia patient when you're communicating. It's really important to have that old-fashioned desk barrier between the two.
Yes.
Hi there. I have a question in regards to patients coming into A&E from nursing homes. I work with these patients, I work in EDs. I found that sometimes it's really hard to work out if someone's having delirium or if they're having acute cerebral event based on lack of information from nursing homes. And I was just wondering if maybe there was scope for having a tool extend into something that's practiced in aged care residences as like a regular screening tool for practitioners there.
Right. So if I was to paraphrase the question so that I understand it correctly, are you asking about tools that residential care facilities could use to identify delirium even before they come to emergency department? Well, I would say yes, and the tool that I would use would be 4AT. Honestly, it's very simple to use. I wish I had an example of it on presentation to show you what it is, but it basically involves asking the patient for their age, date of birth, the location, and the year. That's one component of it. The second component of it is asking the patient to first of all name the months of the year forward, so January, February, March, all the way to December, and then asking them to go backwards from December to January. I don't know if you guys ever tried it, but it's actually somewhat difficult, especially if you're impaired and you have difficulty with maintaining attention, because it's a very good example of having to really focus on, thinking about the forward order and then going backwards. And if you lose track, then you need to think about the forward order again. It actually is fairly resource intensive in terms of being able to do it backwards. And then other components of it is their level of consciousness, and the final component is whether their change of cognition is suddenly changed or not. So it's very easy to use. The beauty of it really is that it's objective. So there are certain things that we can do that's repeatable, and different people, despite doing it, it's fairly, same across the page, and it comes up with a nice wee score at the end of it, which basically tells you possible delirium, definitive delirium, or no delirium. So the beauty of it is that it requires minimal training, and you could use it really anywhere. And there's robust research evidence suggesting that it's useful.
Should be on the desktop now, hopefully. Whereabouts do you think it is? Minimize that. Is that it there? Whereabouts?
It's not that, is it? Oh, this one? Yeah.
Oh, beautiful.
There you go. So alertness, the AMT4, the months backwards is the test of attention, and then the acute change or fluctuating course of cognition. So in Calvary Hospital, we have these forms available, but to save trees, I'd advise my students and training registrars to use their phone instead. It's 21st century, so. Yes, Catherine.
Because delirium is like an acute confusion, does that justify the delay?
So, case by case basis. So, Catherine is a well-respected colleague of mine from Canberra Hospital, Radar Service. Thank you for coming, Catherine. And what she is asking is, many older adults have what we call enduring power of attorney, which is a legal document, which basically states that in a setting when I'm so physically or cognitively unwell to a point where I cannot make decisions for myself, I would trust this person or this group of people to make decisions for me in terms of healthcare, personal care, finances, and whatnot. And what she's asking is, if somebody is experiencing delirium, does it warrant the activation of this document? Because this document is considered inactive until a medical practitioner deems the person to be incapable of making such decisions, and we need to write a letter as such. And in some ways, yes, it is really important because delirium is a very sudden onset condition, but the effects of it can actually last for weeks or even months. And somebody's ability to make decisions about their welfare may be affected for some time to come. And certainly in some patients that I've looked after, I had to activate the enduring power of attorney to assist in that decision-making process. But in most cases, if it's due to simple treatment options within the hospital, then there is something called health attorney, which is a hospital-based form that basically allows the relatives or next of kin to be the decision maker for that hospital admission alone. So that is one way the ACT territory-wide has managed to implement so that some of the decision-making processes in a hospital setting can be streamlined. So I would say case-by-case basis, Catherine. Okay, well, if there are no other questions, thank you all for coming. Oh, that's cool. All done and dusted. Can we